Hello, my name is Dr. Isi. I'm reimagining better ways of thinking, being, and doing when it comes to women, health, well-being, and research. And I'm doing this by focusing on joy, justice, equity, and community. Welcome to my site. This week, we'll be focusing on the subject of risk assessment, race, and ethnicity. Why is it that being a racially minoritized person is associated with increased risk factors for poor health? Surely, melanin is not a risk factor. Let's begin by defining risk. I define risk as a situation involving exposure to danger, hazard, loss, or harm. And we do not like risk in medicine. In fact, our aim is to minimize or ideally eradicate it. This is a cornerstone of providing safe, high-quality care. At the height of the pandemic, our newsreels were filled with shocking but not new statistics about disparate health outcomes for racially minoritized people. Across the life course and multiple body systems, we saw examples of how Black and Brown people were at multiple times increased risk of getting COVID, dying from COVID, being diagnosed with heart disease, diabetes, had adverse mental health outcomes, and in my own field of obstetrics and gynecology, harrowing numbers of how Black women are 3.7 times more likely to die in pregnancy and their babies suffer 150% increased risk of being born stillborn. As a Black woman, I found myself wondering, why are Black women at increased risk of dying? Backing up a bit, what do we even mean by race and ethnicity? Ethnicity is the social group a person belongs to and either identifies with or is identified with by others, as a result of a mix of cultural and other factors which include language, diet, religion, ancestry, and also physical features which are traditionally associated with race. Race and ethnicity are often used interchangeably, and this is incorrect. What is even more incorrect is that race is presumed to be biologically determined. But race is a social and power construct, artificially constructed in the 16th century with 5 categories that placed white Eurocentric bodies, knowledge, and belief systems at the top of the pyramid. Slavery, colonization, and eugenics were justified using arguments of racial differences and hierarchies. Who gets to decide who is Black, Asian, mixed, or who isn't? Are race and ethnicity in the eye of the beholder? Have you ever considered how heterogeneous and inconsistent race and ethnicity categories are? Here in Scotland, we have 19 categories which include white, Black, British, Gypsy, Traveller, Caribbean, Indian, African. How strange that we are comparing skin color for some to cultural groups, to continents, to countries, and even groups of islands. Is it valid to use such a heterogeneous measure in screening and diagnostic and making treatment decisions? There is evidence of more genetic similarities than differences between the various racial categories, and even within the same category, more variation, as evidenced by the mapping of the human genome. And no, there is no Black gene, there is no Asian gene, there is no such thing as a white gene. So just to summarize, I acknowledge 3 things. 1, that race is a social construct and not a biological phenomenon. 2, that race is not the same thing as ethnicity or culture. 3, race is not a proxy for socioeconomic status, income level, or deprivation, although we do see them overlap. Now, even though race is a social construct, racism is real. And exposure to racism has biological consequences on health outcomes. Let's define racism. Professor Cameron Jones defines racism as a system of power, and this system operates by assigning value based on race. And this value is a risk marker for how opportunities and advantages and disadvantages are accumulated across one's life course and between generations. So now I want you to remember just one thing. Race is a risk marker, not a risk factor. Now, risk markers impact the conditions in which you were born, grow up, work, are educated, live, and ultimately die. The so-called social determinants of health. Now, these social determinants of health, affect your access to nutrition, shelter, safe environments free from toxins, pollutants, healthcare access, security, legal systems, and they account for 70 to 80% of your health outcomes. And it's not random that racially minoritized people are overrepresented in poor housing, neighborhoods with higher levels of environmental pollution and toxins, fewer green spaces, heavier police neighborhoods, interactions with the justice system, negative healthcare experiences. These are all examples of how systemic racism manifests. And systemic racism is a social determinant of health because it influences where and how you live and how you're educated, work, and are cared for in institutions. So, in the pathway to poor health outcomes, we need to think of systemic racism and other social determinants of health as upstream factors. And it is so easy to conflate this with race. Race, in many ways, is a way to legitimize and hide these structural factors, which can be hard to measure and difficult or uncomfortable to confront. And these structural factors are exactly what we should be confronting and targeting in our risk assessments to truly reduce risk for our patients. So when we choose, because it is a choice, to ignore these truths, we perpetuate biological essentialism. And this is the belief that some bodies are different, so innately they are damaged, deficient, and diseased. We essentially believe that Black and brown bodies are different, they have thicker skin, higher pain thresholds, denser bones, flat pelvis. As outlined in the Birth Rights Report, systemic racism, not broken bodies, is driving poorer outcomes for racially minoritized pregnant people. But it is easier to focus on broken bodies versus broken systems, especially when you are short on time, staff, and empathy. Risk is stressful. It causes anxiety, it makes us defensive. You probably don't have to think too hard about examples of race-based medicine. Here are some examples that have 3 things in common. They lack evidence, they encourage people in power to profile and stereotype service users, essentially cementing existing or creating new biases, and they lead to worse outcomes by promoting the use of unnecessary interventions or increasing the threshold to allow necessary interventions. Take, for example, the suggestion to induce low-risk racially minoritized pregnant people at 39 weeks, potentially exposing low-risk pregnant people to an unnecessary medical intervention with risks. Race correction for kidney function testing in Black people essentially led to the delayed diagnosis of chronic kidney disease and later referrals for kidney replacement treatment. The use of the vaginal birth after cesarean section calculator, adjusting for Black and Latino people, meant that racially minoritized people were less likely to be supported in having VBACs, and thus resulting in higher cesarean section rates. And the list goes on and on. In this infographic, taken from an academic publication in The Lancet, it explores, as I've summarized, how we perpetrate racial inequities by embedding the non-critical use of race and ethnicity in our medical education. So to reverse this, the authors propose we move from race-based to race-conscious medicine. Ask yourself 3 questions. Is the need for race correction based on robust evidence and statistical analyses? Is there a plausible causal mechanism for the racial differences that justifies the race correction? And would implementing this race correction relieve or worsen health inequities? If your answer to any of these questions is no, you really need to consider why you're using race in the first place. So, take-home messages are: race is a risk marker, not a risk factor. Be critical of using race in diagnostic and screening algorithms. If you do include race and ethnicity in your research or guidelines, be clear exactly what you're defining and how you defined it, and consider the role of systemic racism and the structural determinants of health. Here are a couple more resources you should check out, and if you've enjoyed this video, please share it. If anything struck a nerve, do you agree or disagree, drop me a line, comment, sign up to my newsletter to receive more content which focuses on how we can reimagine better ways of being, thinking, and doing when it comes to health, well-being, women, and equity. Until next time, be well.